All right, welcome everyone to our webinar featuring Dr. Mike Miller. Mike is going to brief us on the COVID situation. First, let me just say a little bit about Lever, who is the host of this webinar. Lever is an economic development group based in North Adams, Massachusetts. And I think the easiest way to understand this is we're primarily an incubator accelerator focused on starting companies that are going to benefit our region by creating jobs. And we have the good fortune of doing some work in health technology, and that's how we've gotten to know Dr. Mike Miller. Mike's been an advisor to Lever and a mentor to many of the teams that we've worked with. Lever organizes an angel network, and that group has a regular call. And a couple of weeks ago, we invited Dr. Miller to speak to that group about COVID-19 to really help investors think about how to look at deals and how to monitor their investments in this era. It was very well received. So we thought we'd have Mike reprise his talk, and he's going to expand it a little bit. At the end, there will be a Q&A opportunity. The way this webinar is set up through Zoom is that only the speakers are unmuted, all the attendees are muted, but you can participate by asking questions on the Q&A function that is at the bottom of your screen. You should see a couple little balloons and it says Q&A underneath them. You can click on those and you can type your question. And if you like a question that someone else asked, you can upvote that, and then that'll bring it to the top of the queue. So that's how the seminar will take place. Let me just say a little bit more about Mike, and then I'll pass the baton. Mike has over 30 years of experience working at the intersections of healthcare, life science, public health, and public policy. Well, like all of that, which is why we appreciate working with him so much. He worked on HIV and AIDS in the early 90s. Actually, he was the first medical officer of the NIH's Office of AIDS Research that was run by Dr. Fauci. And since then he's worked on a wide range of issues, including healthcare access and affordability. Recently, he's been working to help patient groups, pharma, biopharma, entrepreneurs, and so forth on policy advocacy and communications. So tremendous resume from Mike, incredible experience, and we're really fortunate, I think, to have someone with his depth and breadth put some of this into perspective for us. So Mike, you take it from here, please.
Muted. Sorry, I was muted. That was what Jeffrey was. Sorry, I was muted. Let me start over. Thank you, Jeffrey. Thank you, Jade. Thank you, Averill, for setting this all up. I apologize for my technical bother muting. I'm going to talk about the novel coronavirus, what's going on with the current situation, some data uncertainties, where we're going, where we, how we're going to get forward, and what we need to know moving forward. And give you guys a framework for thinking about a lot of different things you're probably hearing about and talking to people about, being told what you should and shouldn't do. So this is my agenda and the overview. First of all, I want to go a little disclaimer. These are my insights and analysis, not necessarily reflective of Lever or anybody else. There's a lot of heat and contentiousness around some of these things. So I'd ask that you not like widely distribute this or give me a lot of attribution, even though publicity is great. But as we've seen, there's a lot of heat and emotion around some of these things around what's going on. I'm going to give you some terminology and definitions, talk about the data and how it's being used for modeling, what that means, a little bit of scenarios and projections, maybe address some misconceptions, and leave time for Q&A. First of all, Jeffrey talked about, being synthetic. That's my approach of looking at where things are going and how we think about different pieces. This is a slide I've used for a lot of different talks about what the healthcare system in the US is all about. Now, it's not just, if I can use my little pointer here, there's healthcare financing, there's healthcare delivery, there's healthcare research, there's public health, there's social services, and there's what goes on in the community. And all those things intersect and interact to try and produce better health for the community, or less health, depending on how if things are not going well. So I think it's important when people talking about the pandemic, this is really a good model for thinking about all the different pieces that are having to interact, how we address what's going on. In terms of terminology and definition, just a level set for everybody. Virus is the SARS-CoV-2 virus. It's got that name because it's like the SARS virus in 2003, but a little different. Disease it causes is COVID-19, which causes the illness. There's 3 kinds of testing. There's a testing for the virus in people, which is an RNA test. You actually don't grow the virus like you would like a culture or bacterial infection. There's testing for antibodies. And this is when I gave the talk 11 days ago. This was something I didn't really talk very much about. In the last week and a half, it's suddenly become a very hot, important issue. And I'll explain why. Because it's a way for potentially to test who's been infected in the community and possibly does an individual have immunity. And then there's also testing for the viral RNA in the surfaces or airdrops in the environment. That's kind of been less of a factor. People are less concerned about, being infected from their mail. That's kind of been worked out, although more research is going on. So in terms of the antibodies testing, and I'm hoping that your screen isn't showing this little thing here. Maybe I can move that. There we go. Antibody testing, and this is just a basic graph of how antibodies are produced by the body after being hit with an antigen, which virus has a bunch of antigens on it. There's 2 kinds of antibodies. I won't go into depth. IgM, IgG. IgM comes first, less specific. IgG is more specific, so that's the thing you want to test for. The thing to recognize, and I've added these little plural S's here, is when you get hit with an infection, you don't produce one antibody. There's a whole range of antibodies because the antigen of the virus has a bunch of different things sticking out. The antibodies are created in response to all the different antigens. It's important. I'll talk about that in a minute why. If I can move the slide forward. There we go. So the timeline for pandemics or outbreaks. This is just a level set so you guys have an idea. First thing that happens, you want to prevent the initial spread. We're way past that, obviously. You want to contain it if it's gone, out from just the initial outbreak. We're past that too because we're in a pandemic. I mean, what happened in 2003 with SARS was their initial spread, and they contained it. There were a few hot spots, Toronto, a couple places, but it was contained. We're now in the stage of mitigation, which we can talk a lot more about. We're now in the US about a month in, some other countries several months in. Just everybody wants to know how long does that last. Next phase is our control, hopefully with treatment, and how many months that can take, still being figured out. I'll talk about treatment approaches in a minute. Then there's prevention with a vaccine. That's hopefully in 2021. And then the last step is really preparing to prevent any future outbreaks, prevent the spread and the containment. I'm not going to talk about that. We can do that in Q&A if you want. Data modeling and projections. First of all, models can be good if the data that goes into them is only mediocre or poor, and what results you get can be not so good. And the problem here in the US is because we didn't have availability of tests, modeling was not great. The results of the models was not great because we didn't have the good data to put in. An example of that is even the reported deaths. If somebody wasn't tested and were positive for the SARS virus, and if they died, their death might have been reported as pneumonia, respiratory failure, not as a COVID-19 death. Then there's the antibody surveillance and immunity testing that can happen in the community If we don't have that data, we don't really know how many people have been infected. There's also other modeling problems around the variability of the government's response and personal behaviors. If you're a modeler, you need to know how people are going to react and what the government's going to do in terms of PPEs and providing access, being able to provide ventilators and all that. Those are all variables that went into the modeling. I just want to point out, the U.S. News and World Report had an article 2 weeks ago, basically concluded the only thing certain about the modeling is the uncertainty. In the Annals of Internal Medicine, a leading medical journal, had an article a week ago cautioning about even the substance of the model being used by the University of Washington, saying it may have problems that are giving us challenging or unpredictable results. So some individual and community factors in the modeling. First of all, age, obviously everybody knows that's a factor. The older you are, the higher risk you are for having serious disease or dying. Men look like they're roughly twice as likely to get serious disease or to die from the virus. And there have been some articles about that, bad COVID-19 disease. Obviously, underlying health problems, particularly pulmonary problems. People are smoking, tobacco or marijuana, or probably even vaping. I haven't seen anything about vaping, but I suspect that's another cause of pulmonary injury, can lead to worse disease. There's also been speculation that if you get a higher initial viral dose, that could lead to a worse 19 disease. Obviously, community factors. If you can't socially isolate because you live in a very densely populated area, it's one of the problems in New York City. And you can't socially distance or have good social hygiene, that can be also a problem in mitigating and leading to modeling problems. That needs to get built into the modeling. I just want to quickly point out that in terms of all the discussion about the modeling, the projections, and the numbers that people are throwing around, it's really important to distinguish between a professional who's saying something and somebody who's a pundit. Characterize this around science and pseudoscience, if you drink the Kool-Aid or not. And there was this article that came out about 2 weeks ago. The president's trade advisor was allegedly stated that he, as a social scientist, was just as qualified to be making these predictions or making a recommendation around scientific matters. So let's go to some scenarios. We're now in the mitigation phase. The idea behind mitigation is to reduce the spread. There's this term called the R factor, R naught or RT. And basically what that means is if one person is infected, how many other people are they going to infect? If they're infecting more than one person, 1.5, two people on average, then infection is going to spread and grow and more people are going to get infected. If you get that R number below 1, then you start reducing the spread of the infection. And you do that through social distancing, isolation, masks, the other kinds of things we're talking about. The latest thing that's coming out, you may be hearing more and more about, is contact tracing. Somebody who's infected, they get identified, they get tested. You can't do contact tracing unless you've got access to the testing for the virus, find out who's actually infected. Somebody's identified as newly infected, you then talk to them and find out where they've been, where they might have got infected, and then track down everybody they had contact with and alert them to get them tested and try and reduce that R number. It's very labor intensive, but very effective. South Korea's done that. Massachusetts is starting to do that. The goal is, again, to buy time to prevent the health system overload, so-called flatten the curve, and then buy time for ability for treatment. Some other scenarios, crush the curve. Harvey Feinberg is leading the National Academy of Medicine's efforts around these emerging infections. Wrote an article about that. In New Zealand, actually, they called it squash the curve. They essentially shut down the whole country. They stopped travel in and out of the islands. People are staying at home. They're testing people. They're contact tracing. Really shut down the spread of the virus. And they've had very few cases. And I think their deaths, when I looked, were in the single digits. There's other scenarios. The quick wave is hypothetical, but highly unlikely if there's a really high number of asymptomatic infections. But other countries are diving into the curve, so to speak, instead of trying to avoid it. They're keeping up, their schools are open, their recreation, they're prioritizing economic activity over public health. We'll see how that happens. Potential treatment types. Now we're moving in sort of looking forward to the next phase. The things got to realize is that treatment needs to be specific to the state of the disease. Treat the virus with earlier mild infections and moderate symptoms. More serious disease, people with pneumonia end up in the ICU or on ventilators. Oftentimes, their own immune system is attacking themselves, so-called cytokine storm. in developing these treatments, there's been a lot of talk, and this goes back to my time when I was working on HIV/AIDS treatments in the 90s, and even since then. Risks and benefits for improved medicines or things that are being developed needs to be considered. You can't just throw everything out there and hope it works without considering what the risks are and figuring out how you're going to determine does it really work. First thing that people are using right now, and it's in clinical trials, is plasma serum from people who've recovered from COVID-19 disease. They've developed antibodies in their blood. They can be tested, and then they can donate blood, and the serum extracted. And for every person who donates blood who's recovered from COVID-19, that can be used to treat probably 2 people with serious disease. It can't be remanufactured or synthesized. That's something else like that. That's being used, and it's a technique that's been around for a long, long time, treated other infectious outbreaks, going back decades. So the next step is developing new biologics or drugs, or finding things already approved can be used. There's the immune system modulators, which is really try and fight that cytokine storm to keep the body's own immune system from fighting back. Antiviral drugs, there's a variety of those that have been developed for other viral infections. They're being looked at, and new antivirals are being developed. Neutralizing monoclonal antibodies, something I want to point out here. This is like the plasma serum from people who've recovered. Just checking my time. And it's actually manufactured. So you can manufacture a whole bunch of this and then give it to people when they've got mild, moderate, even mildly severe disease. But the key thing is that you just can't come up with any antibody from responding to the virus. It's got to be a neutralizing antibody, because there can be antibodies that actually help the virus enter the cell and can make the disease worse. And that's the reason why when we're talking about vaccines, which is ultimately the goal, everybody gets a vaccine, really prevent the spread, everybody's got immunity, gets the vaccine, you've got to make sure that that vaccine is producing neutralizing antibodies, not what's called antibodies to potentiate antibody-dependent enhancement. So you've got to, the reason why these things take a long time, you've got to make sure that you're getting the right response you want. This is a quick pie chart with the Millikan Institute Faster Cures Division. They've been tracking the things that are in the research pipeline. There's over 200 things in development right now. This was updated yesterday. Since last week, they've added about 20 or 30 more. And you'll see there's a lot of vaccine candidates, a lot of antivirals, and antibodies, the monoclonal antibodies that are being tried to be developed, and then a variety of other things that are people are trying. My expectations, well, clinically, obviously, we're trying to avoid overloading the healthcare system, and we're cutting back on non-emergency, non-COVID services, dental care, preventive services, not non-emergent surgeries. There's been problems with this, though, of course. People who are in the middle of chemotherapy or might want to be starting chemotherapy for cancer that might be not incredibly aggressive. Of course, you want to start it. People say, well, we're on delay because we really want you coming to the hospital and getting infected and being immunosuppressed from your chemotherapy. In terms of the economy, people have asked me this, and this was the focus talk 11 days ago. When do we can return to something in normalcy or normal-ish? Well, you know, I said this a week and a half ago. I think it's going to be a patchwork of unwinding the social restrictions. We're seeing discussions about that all over the place now. From the public health and scientific perspective, it depends upon data about how many people have the virus, how many people have immunity, the ability to continue the viral testing and mitigate as are needed, and then ability to, if the virus starts to break out, if there is a second wave or there's a rebound in the virus, ability to reinstitute some of those social restrictions and prevent the spread, get that R factor back down below 1. And of course, that's all balanced by political social will for tolerance of risk. So those are the two competing factors here. Long term, I think we're going to see some public health, greater focus on infrastructure, public health, and as a priority. I think we're going to see some healthcare reorganization issues around to make sure the supply chain for outbreaks like this are serious problems. The medical industry, the biotech, biopharma, medtech, I think we're going to see a greater emphasis on vaccines and antivirals, and certainly on supply chain. One of the challenges around doing the testing for the virus and testing for the antibodies has been around ability to get supply chain for the materials and the reagents that go into those tests. That's been one problem by getting enough testing out in the community. Healthcare financing, I think we're going to see some significant things change there, some changes to models and projections, particularly around Medicare and a few other things. And the economy, you know, it's how are people going to react back to work? What kind of activities are they going to eagerly go back to? What kind of industries are going to rebound quickly and which are not? I mean, I frankly don't see people flocking to cruise ships really soon. In terms of the job market, you know, I think there's going to be an examination around minimum wage, living wage, but also around paid sick leave. Because people who, you know, if they don't have paid sick leave, and even if they're an hourly worker or if you're a salaried employee, then, you know, you've got an incentive to go to work when you're sick. And that's never been a good idea. I've been having this discussion with people for 20 years about the problems of the single block of paid time off for vacation or sick leave. It's an incentive to go to work while you're sick, so you have more vacation time. The misconceptions, I won't go into this deeply, but, you know, correlation doesn't prove causation. So stories you hear that are anecdotes, or people say, well, there's this that's happening and that that's happening, and that proves that this causes, you know, two things are connected. It's not. That's why we need research and science. Dr. Google, depending on the website you go to, can be okay, but there's a lot of misinformation out there, particularly on sort of social media and things you hear from friends of friends of friends. Just to conclude, so we have time for Q&A, because I think I'm at my 15 minutes or so. We need more data about the virus, about treatments, around how to continue social isolation and mitigation of spread, particularly contact tracing and more testing for the virus, testing for the antibodies, showing which antibodies are reliable, tested for, and that the tests are reliable. One thing that's been coming up recently, the last 3 days, is the number of antibody tests that are out there. The FDA has allowed, it's more than 90 tests out there, but they haven't been really validated as to which antibodies they're testing, what's their false positive, what's their false negatives. About half of them are being imported from China. There's some quality control problems. And of course, it hasn't begun to be shown which antibodies and what levels really confer immunity preventing future infection. The economy, and just to reiterate, I think we're going to see it slowly, sporadically, and unevenly resume. And that's the short term, and that's going to depend on the easy testing. In the medium term, if infections climb again, I think we could see, you know, a closing down of parts of the economy that are problematic, or closing down of activities, or aggregation, you know, limiting size of people getting together again. I do think we'll certainly see telemedicine grow significantly coming out of this. It's been shown before to be good. There were some barriers. Those barriers have been taken away. I don't think they'll be put back. And then there's the last thing is the federal financial fallout. Through the necessary and appropriate financial bills that's been passed, we've added about $2 billion to the federal debt, and that's going to have to be addressed at some point. So thank you guys. Appreciate your listening to this. I'm looking forward to the Q&A and to talking to you all about this and other things as we move forward. And I'll stop sharing the screen and hopefully not mute myself again. Did that come out okay, Jeffrey?
Yeah, great job. I'm going to clap for everybody. Okay.
I apologize for my muting and starting.
We sorted it out. Yeah, we've got some questions here for you, Mike. Let me just remind everyone that if you'd like to ask a question, if you go to the bottom of your Zoom screen or the window that's got some menu options, you'll see an option called Q&A. And you can just click on that and type in your question. And if you see a question that someone else has asked that you would really like to have asked, then just hit the thumbs up there and it'll come up to the top. So we do have some questions coming in, Mike. Here's the first one for you from Guy Fish, Dr. Fish. Can contact tracing be done if the spread is already above 35% of the population, like in Chelsea, Mass?
Well, you can, I didn't realize Chelsea is above 35%. I've seen some statistics, but I think the size of the testing samples were rather small. So that's a data problem in terms of the modeling. Is it really 35%, or do they have selection bias to who they tested and found out that there was that number? And was that, you know, antibody testing or not? Contact tracing can certainly be done. You've got to identify who the person was in your initial person you're contacting and tracing from, who they were in contact with, and go test them for the virus. can also test them for the antibodies. So if they actually have a positive antibody test, you know they were infected some point in the past. So certainly it can be done. Once there's herd immunity, which means people who have been either exposed to the virus and have immunity or have a vaccine gets above about 80, 90%, 70, 80, 90%, depending on how infectious the thing is. That's herd immunity. And then necessarily contact tracing might not be as effective then, but 35% is way too low. Thanks, Guy. Thanks for calling in, for logging in.
Here's a question from Malcolm Smith, who's wondering, is there anything useful coming out of countries like Brazil or Nicaragua or Sweden that, as he writes, have leaned into the virus?
Not that I've seen so far, but the question is, are they, you know, are they testing? What data are they collecting? Certainly, they should be knowing if their ICUs are getting overloaded, if they're, you know, having a lot of high deaths. So far, we haven't seen that. I would expect a country like Sweden to actually have good data and be vigilant in their public health monitoring. And I would expect, because some of the other neighboring countries have actually been very good in putting in mitigation effects, like, well, I was going to say the U.S., but some other countries have done more systematically. If Sweden has a problem, I would expect them to know it and to put in place some things. Nicaragua, Brazil, their attitude seems to be balancing, you know, if I can get my hands up here, the balance of we're just going to keep the economy open, we're just going to pull through this. That seems to be their attitude. So if there are bad public health outcomes, the political social will seems to be that's okay. So I have not seen the data yet, but I expect it to be coming.
All right, thank you. Mike, here's another question, which I wasn't aware of. Tony Sirk notes that one of the governors in the United States imported 500,000 tests from South Korea. And we want to know what you have to say about tests that we're importing from other places. And also, what do you have to say about global cooperation in the World Health Organization?
Thanks for that easy question, Tony. You know, I think it depends where you import the tests from. If you're validating them, what kind of assurance you have that what you're getting is useful and is good quality control. South Korea has a very vibrant, you know, not only, you know, silicon tech, you know, communications kind of software and cell phones and all that. They've got actually a very sophisticated biotech industry too. I would think that they would have the capability for producing that kind of thing. I will note that there's been situations I've heard of where somebody's healthcare systems have purchased a lot of PPE from other countries, and they've got it, and then they started looking at it and realized that there was tremendous variability in the quality of the mass of PPEs, of masks and other things that they bought. Some of the masks were good filtering, and other ones weren't, and it wasn't just they were different brands, it was just quality control of the manufacturing. So it's certainly something that needs to be looked at. Frankly, given the number of different companies producing tests, even here in the U.S., I think that's something of concern too. And in terms of global cooperation, you know, it should have happened. It didn't happen the way it was designed to in this current pandemic. It's worked better in the past. I think it's something for the global community to talk about, you know, after we're through this. And can reevaluate how to move forward.
Thanks. And kind of follow-up question on the testing. A couple of folks are wondering about the accuracy of both the viral and the antibody tests. And do you have a feel for false positive, false negative rates? And do you have an idea of how accurate do they actually need to be?
It's a great question. Let me just take it in two separate, the viral test and the antibody test. Viral test that people get with a nasal swab that goes all the way to the way back of your nose, it actually tests for the RNA of the virus. So there's two issues around the accuracy of the test. One is, was the sample accurate? There's been concerns about just taking it like right around your outside of your nose, sorry for the graphic there, versus where it goes all the way to the back. It's basically where the back of the nose meets the top of the throat, which is where the sample is supposed to be taken. If the sample is inadequate, then you can get false negatives. The accuracy of the actual PCR testing, it's very sensitive, felt to be pretty accurate. It could be producing some false positives. If somebody's recovered from the viral infection, they're no longer contagious, but there's still some RNA floating around in their body, which may be, there's been other sampling sites that people talked about being able to quote unquote recover, if I can figure out the quote unquote recover the virus, but they're actually just recovering RNA that you can test with the PCR, which amplifies it. In terms of the antibody tests, like I said, the FDA has allowed 90 plus of these tests to be used. And actually, the federal legislation requires that insurers pay for those tests, as well as the viral RNA tests. I think there's a big concern about the accuracy of them, particularly since a lot of them are coming from other countries. And I'll give you a general dichotomy here. Two kinds of tests. One is where you go and they actually take your blood and put it in a tube, and it's run, in a real, real lab. They, through big machines and stuff. The other kind is where they just do a finger prick, and it's a point of care test. It's kind of like equivalent of a pregnancy test or the measuring your sugar level for a diabetic. My understanding is those home tests or point of care tests the doctor can do in the office, stick your finger and tell you in 2 or 4 hours. That's likely to be less accurate. The antibody test, you've also got to ask, what antibodies is it testing for? Is it testing for one antibody? Is it testing for multiple antibodies? You hopefully want to have it testing for the antibody that comes second, which I can never remember. I think it's the IgG. Jeffrey's nodding, so that's right. I always get that confused. Again, is it testing for actually a neutralizing antibody or not? And what level is it testing? Is it just saying there are antibodies or not? And the other thing is, generally across all testing, if there's a low prevalence, meaning that there's really not many people that are actually positive for whatever you're testing for, then that gives you a higher likelihood that you're going to have false tests, false positives. Because if only 1 out of 1,000 people are actually positive, the test is a little bit less accurate, and you've got a few people that you have false positives, then the rate of false positives is going to be much higher. If you're pretty sure, if you've got a good indication this is a test somebody is likely to be positive for, that gives you more accurate results. This is a statistical thing. But there's a lot of this needs to be worked out. In particular, I'm concerned about the antibody testing, because I've heard stories and read things and talked to people about cases that are just getting access to these antibody tests and giving to people and frankly making a lot of money, and it's not really good. The FDA does require disclosures about it not being FDA approved and this and that, and it actually can have cross-reactivity with other coronaviruses, not SARS-CoV-2. That can give a false positive if somebody had some other coronavirus in the past. There's at least 8 of them that are known. And it's a real Wild West. And I've advised people who I know who've tested positive or presumptively had COVID-19 not to get a test and just rely on it. It's like, okay, now I'm immune. I think it's an issue that really needs to be addressed moving forward if we're going to figure out how to, unwind some of the social isolation mitigation activities.
So, Mike, I've caught myself fantasizing about getting tested for antibody and testing positive, and then getting the knowledge that I'm now immune and I didn't get sick. But that's
it's a real concern, because if 50% of people or 60% of people get the infection and don't have any symptoms, you say, hey, well, maybe I did have it. I'm going to go find out.
Right.
And
well, there were a couple questions on this that I wanted to get to from the audience. One was from Tony Sturck. He's wondering if it's known that once you've had the virus and you've had an immune response, is that immunity now 100%? That's one part of the question. And then a related question is about herd immunity. Hugh Daly had heard that if you have 65% of a population that's had the virus and is immune, then effectively the herd is immune. So you want to comment on those two things,
Yeah,
please?
the first thing is, it needs to be shown that which antibodies at what level. So you got to have the right antibody test, and it's got to be able to quantify how much presence of the antibodies you have. It's got to be shown that that does confer immunity. That's going to take a little bit of doing. There's a variety of ways to do it. You don't just, say, okay, you've got this level of antibodies, we're going to expose you to the virus again to make sure you don't get it. There's no human experimentation on that. It's more of a population epidemiological study. And that's not known. The other thing that's not known is how long, if once that's determined, how long that immunity lasts. It seems viruses like SARS-CoV-2 that will do get immunity and that it does last for quite a while, whether that's 1 year, 2 years, 3 years, 9 months, 45 months, it's hard to know. And of course, it's not going to be the same for everybody. But once that antibody test is validated as you've got antibodies at these antibodies at this level, that's something that can be tested for moving forward. Herd immunity depends upon how infectious virus is innately. Measles is incredibly infectious. It just spreads like wildfire. But to have herd immunity for measles, you need a lot more people who are vaccinated and immune than you would for something that's a lot less infectious. That's maybe doesn't get to your 65% number. Most times I've heard about herd immunity for infectious diseases that are easily spread, it's higher than 65%. And it seems like this SARS-CoV-2 virus is pretty infectious and pretty transmissible. Not like measles, but more so than maybe a lot of other things that health communities used to dealing with.
Thank you. Kendra Zamza asks, do you expect virus mutations to make it difficult to get accurate treatments or effective vaccines?
I was just reading an article about this. Doesn't seem like this virus is mutating very rapidly at all. And the people looking at this, partly they're trying to figure out where it came from. It came from bats, and they're disproving some of the rumors, the misinformation that came out of a lab, was developed in a lab or anything like that. So people are looking at that. It seems to be mutating very slowly, and that knowledge about where the mutations are happening is useful for people developing monoclonal antibodies and vaccines. You want to make sure you're ideally targeting areas that are not mutating at all. And there isn't actually a vaccine approach with actually targeting the RNA itself, as opposed to the coating, the capsule that the virus has around the RNA. A virus is actually a very simple thing. So like a conglomeration of proteins with RNA in the middle. They're very tiny and very simple.
Mm-hmm. Thank you.
This virus has RNA in the middle. Other viruses have DNA. But technical point.
I've changed gears a little bit, but getting back to a little bit to the question about leaning in certain countries. So Abby Minando is asking, or making the point that since hospitals are very expensive to maintain, and by the way, my colleague's wife works at the hospital in Bennington, mm-hmm. and he said last week they had a day at the hospital where there were 0 patients, 0 inpatients in the entire sense of the hospital.
Because they're waiting for the surge.
Right.
Preparing for it, yeah.
Right, and that's very, very expensive. I mean, they're still staffed, and there's no revenue coming in. Against the social distancing, which was done to avoid the surge and the overflow in the hospitals. So, how do you see that? I mean, couldn't you make the case that we should loosen up social distancing and kind of, now that somehow manage it so that the rate of infections is
even.
We're moving through the epidemic, but we're not at a rate that we're overwhelming hospitals.
Well,
can that case be made?
It can be. I mean, that's part of well, there's 2 things. One, if you really squash the curve like New Zealand has done, you can essentially wipe out the virus, and then you've got to go to a case where anybody who comes into the country gets tested, gets quarantined, and you prevent the virus from getting back into your community, whatever that is. In New Zealand, they've got the unique situation where it's relatively rural and they're an island. Hawaii, for the same reasons, had a relatively low rate. But it's a trade-off. And you've got older people, sick people, who've got multiple problems, health problems, that you're making a calculation about, is it okay? Is it worth the risk that somehow they could get infected and die? One of the statistics that's I'm a little bit reticent to, I didn't put in the presentation, but it seems like in nursing homes, 10, 15, maybe 20% of people in a lot of nursing homes are dying from COVID-19. Nursing home here in Williamstown, statistics are out, 15 out of 130 people have died from COVID-19, 70 have become infected. They're older, they got multiple health problems, they can't socially isolate. It's like every risk factor you want. So that's the challenge. I mean, I would argue that, you know, the wave is not spreading evenly across the country. It's not like a snowstorm that just comes and goes, you know, wherever, from Gulf Coast up to England or from west to east. It spreads out in hotspots and pockets. The fact that the Bennington Hospital has excess capacity, probably a good thing, is if the hospital in Albany or the hospital in Brattleboro or the hospital in Pittsfield suddenly got overwhelmed, it could be diverting patients. It's like any other mass health problem. You have different abilities to transfer patients or transfer staff or resources from one to the other. I think, you know, the problem is people haven't figured out where those resources can go and how quickly we can unleash. There have been, just to be clear of what's going on in Bennington, there have been cases up there. There have been, I believe, deaths in Bennington County from COVID-19. It's not like Vermont hasn't had any cases, or southwestern Vermont hasn't had any. Just, you know, they've been so far spared being overwhelmed. Again, the goal is you keep that curve really low. I've got that graph I didn't show about squashing the curve or squashing the cat, as some people say. Because you want to keep that down, you reduce the deaths, you reduce the ability, you reduce the likelihood the health system is going to get overwhelmed, and hopefully you get to a point where we've got better treatments. Like I said, there's a whole slew of treatment out there, and there just was some other report I was reading about that. And, you know, there is a problem of having to delay or prevent regular health care. I have a friend who's a cardiologist in California. You know, his group practice that employed him laid him off because they're not doing any work anymore. I'm not real worried about him. When this will open up again and he'll find work and it'll happen. That may be part of what happens in reorganizing the healthcare system. In cardiology, for example, will there be more medical treatment and less surgical interventional treatment for, you know, heart disease? I've been an ongoing debate for 10 years, which is better. Maybe now the pendulum will swing back more towards medical care that people don't have to go to the hospital for, because they'll be concerned about getting, you know, infected with SARS-CoV-2 or something else. Yet to be seen, yet to be determined.
Yeah.
Thanks, Abby. Good question.
A little bit related to risk factors, and you mentioned in the nursing homes, you know, some of these patients are just a litany of risk factors. Dr. Fish notes that he has heard that smokers are less likely to end up with acute respiratory distress syndrome complications in COVID. Have you heard that?
I have not heard that. In fact, I've heard the opposite. And I did hear one thing specifically that said that, you know, marijuana smoking was just like tobacco smoking as a risk factor. There's been a lot of discussion. Again, this is a little bit of clinical, and Guy will appreciate this. For all sorts of different kinds of pneumonia. Viral pneumonia that's caused by SARS-CoV-2 is very different than when people get a bacterial pneumonia. The fluid that's in their lungs is much more liquid, and that requires a different kind of ICU care, respirator care, ventilator settings, and things like that, and other sorts of treatment. Just an article I was reading that, in fact, what may happen is they get some fluid in their lungs. They don't feel congested. Their lungs are still pliable. But they lose the ability to blow off CO. They can blow off CO2, but they're not getting oxygen in their blood. Those oxygen levels drop. They don't feel distressed because the physiological symptom of being short of breath, oftentimes from high CO2 levels, which a lot of times people don't have early in the disease. Then once their pneumonia progresses, all of a sudden they crash because then their CO2 level goes way up. And that's seen clinically, and it seemed to be thought was happening. It's a different kind of pneumonia than people have bacterial, or what was happening when people were getting contaminated vaping products, what was probably something called lipoid pneumonia, which is not an infection, it's just a reaction, a chemical assault on the lung. So again, when you hear pneumonia, it's not just one thing.
Yeah, I saw there's a really interesting opinion piece. It was in the Times this morning about just that point. An ER doc had observed this, and my takeaway from that was, oh my gosh, we need to figure out how to do a wide scale, a home pulse oximetry.
Well,
So,
that's what they were recommending, is that people who tested positive for the virus not just get a thermometer, but they get a pulse oximeter, which is relatively easy to use, and I guess you can get them at the pharmacy. They may not be cheap, but may be useful for monitoring people moving forward, and they can be disinfected and reused too.
Yeah. Well, let's. We just got a few minutes left. Let's kind of get back to the big picture stuff for a minute. Why? Is there anything that can be done to accelerate the technology to support the response in terms of, treatments, vaccines, that sort of thing? Is it moving as quickly as it can?
I've heard some concerns about this, that there's perceived lack of coordination, that what's going on. But the NIH actually came out last Friday with a press release, something I'd heard about. They've made it public, that the NIH is working with all the major companies that are in this space, those things in that pie chart, to help coordinate activities. Because actually one of the real challenges of moving things as quickly as possible through research and through clinical development particularly, is enrolling patients in clinical trials. So if you need 400 people in a clinical trial, say, which is maybe an average number, roughly, something of treating an infection, you can't enroll 400 people at once. If you've got multiple trials all looking to enroll people, they could be competing and they can all delay getting their 400, and that just stretches out the timeline when they're completed and before they can analyze their data. So there's been some coordination across the industry. The NIH is taking the coordinating role on this, try and make things go faster. They're actually, they're getting a lot of cooperation, so they can prioritize which of the things need to go first, how to allocate sites for enrolling patients in the clinical trials and whatnot. This was a problem actually in the early AIDS days when I was working on this in the early 90s, where with expanded access to a lot of the things that were in trials, then some news would pop up like, oh, this thing that's in trials, it's really bad. It had this bad effect. And people were dropping out of trials. They weren't enrolling, or they were preferentially going for the expanded access and not enrolling in trials. It actually delayed the time for developing things to prove which treatments for treating HIV were good and which were not. So that I think people recognize that as a problem, and actually the NIH and industry were keeping it below the radar as they were trying to work this out, and then they went public with it. The NIH press release on Friday. And there's also, in terms of vaccines, you may have heard, there's a variety of vaccines and treatment. Companies are not just saying, okay, we're going to do the research, and then if we find something that's useful, looks like it's good, and we get it approved, then we're going to build manufacturing facilities. Companies are building manufacturing facilities very early so that they'll have them ready to go as soon as something is shown to work. And actually, Bill Gates, the Gates Foundation, came out about a week ago. He said they're building 7 different vaccine production plants because different vaccines require different technologies for actually doing the manufacturing. So he's investing something $1 billion or more dollars to actually build these 7 facilities so that they'll be ready to go for whichever vaccines are proved to be effective. And he says he recognizes that probably 2 of them will end up producing vaccines, and the other 5 will just be, sunk costs, and they'll shut them down and do whatever they want with them. So people are getting ready and doing everything they can in parallel to have a treatment, vaccine, produced as quickly as possible.
All right, and then I'll ask the last question. What do you think, Mike, are the 3 most important things that need to be done so that stores and restaurants can reopen? We can start to get back to life as we knew it.
Well, I'm not sure we're going to get life as we knew it. Life is always different as you move forward. It's making the best things we can do with what we've got and what makes the most sense. I mean, we're not going back to the life we had of dial-up phones and and black and white TVs either. We'll keep moving forward with all those kinds of things. I think one thing that really needs to be done, and some places are starting to do it, is contact tracing. Massachusetts is starting to roll that out. It costs money. It's very labor intensive. I think the governor said they're going to hire 1,000 people to do contact tracing. They've hired like 100 so far. It doesn't take particular skills and technical skill set. It just takes people skills and the ability to use a little bit of technology and have an understanding of what you're doing. That's one, contact tracing. In order to do that contact tracing, you've got to be able to test for the virus and test for the antibody. And I guess I'll combine the last two. Well, second thing is availability of tests and validation of what the tests are, particularly the antibody tests, what they are, what they mean, does it have immunity, and how long does it last. And the third thing is, I think, and that's happening now, is sort of regional coordination. We've seen the New England governors or the Northeast governors get together and say, we're going to coordinate our reopening of different aspects of the economy. The West Coast governors, the upper Midwest governors all got together and said, we're going to do this in coordination. So I think those are the three things: coordinating their activities, having better data about who's infected, who's not, who has immunity, and doing the contact tracing to really keep that R level down, so that if there are, new infections or outtakes, or somebody comes in from another country, then that can be quickly squashed or contained. I guess would be a better term. We're not squashing people; we're just containing the spread of the infection. Then, obviously, the treatment will throw forth. We need treatments, because I think if people were confident that if they got mild or moderate diseases, disease from having an infection, they could get the test, show that it was actually the COVID-19 disease. It was a relatively effective, safe, easy treatment. Would be less concerned about getting infected. For people who had, health problems, severe, immunocompromise, those people even before this were they're counseled not to go out and expose themselves to large crowds, because a lot of other infections, whether it's influenza or all sorts of other things, put them at risk. So their health practices, their socialization practices, would be like they were before as well, with a heightened sense of, awareness, I think. Thank you, Jeffrey. And thank you, Jade and Averill, for making this happen. For all of you, calling in.
Yeah, thank you, Mike. And Abby Menando echoes our gratitude. Super informative. It's really special to be able to talk with someone and hear from someone with such terrific insight. Maybe we'll do it again. We'll see. Another question we had was whether this would be available as a recording later. And I believe it will be. We need to get permission from Dr. Miller, but we will try to make that available to folks who participated.
Yeah, no, I think Jade said she's recording it, and it should be. And hopefully I haven't said anything that's going to get me to much attention on the inner tube. If anybody has any other questions, you know how to find me. I'm more than happy to talk about this going forward. The biggest challenge, frankly, and Jeff and I have talked about this, in the 11 days since I did this last time, so much has changed. It's like drinking from multiple fire hoses coming from every direction. I will say, I've tried to keep up and provide some synthesis of all the things that are going on, but I always know there are lots of people out there who, in particular areas, know a lot more about individual things, specific parts of this than I do. So I try and reach out or read what they've been writing or saying and learn from the experts and kind of integrate that into my thinking about the whole approach and a whole framework of where we're going and why. So thank you again, Jeffrey, and everybody.
Thank you. We're the beneficiaries of your scholarship. Thank you, Mike.
My pleasure.
Take care, everyone.
Yeah, be well. Thanks.